Good evening, everyone. Welcome to the New Teeth Now webinar. My name is Bianca and I'm here with Dr. Richards. Thank you for tuning into the webinar tonight. We are so happy to have you. And tonight we're going to talk about full mouth implants and all that New Teeth Now has to offer. So, Dr. Richards, how was your 4th of July?
My 4th of July was wonderful. How was yours?
It was pretty good. I had a good time.
Good.
So
Fantastic. It was nice being off for a few days and taking it easy.
Definitely.
So, yeah, enjoyed it. So we've been doing these webinars for a number of years, and we have received a lot of good feedback. So Dr. Kirkpatrick and I are going to continue to do these informational webinars. These webinars are broadcast out of our office in Lakeland, Florida, the New Teeth Now office in Lakeland, Florida. And that's our only location. We're centrally located in Florida, about halfway between Orlando and Tampa, and makes it a really nice destination type of situation for people that want to come from longer distances. We've had people from New York recently, Chicago, Alaska, coming from all over, and they always enjoy coming to the Central Florida area. Just a little bit about me. This is not about me, it's about New Teeth Now, but I'm a Lakeland native. I came back and started my practice in 1980, going on 40 years now, and it just so happens that I got into the oral surgery business and the dental implant business at sort of the birth of modern implants in the United States. Back in the late 70s, we were doing various types of implants, Ramus frames and other non-precision type root form implants. But when the Brandmark system was introduced into the United States back in about 83, we began doing these full arch fixed cases. And when I tell people that, they're always shocked that these cases, these types of procedures, these full arch procedures have been done since the early 80s. And it's just recently, with a lot of people advertising about this, that the public is certainly becoming more aware of these procedures. So just a little bit of background there. We can kind of get right into the meat of things here. Was there anything, Bianca, you wanted to add?
No, I just wanted to go right in and let's talk a little bit about what the upper and lower hybrids look like.
At New Teeth Now, basically what we're talking about is providing for our patient a full arch of teeth, either the upper, the lower, or both, on the same day that they have the procedure. So typically a person would come in around 7 or 7:15. They'd be placed under general anesthesia by one of our nurse anesthetists. The procedure would be performed, as I said, either the upper arch, the lower arch, or both. If it's both arches, typically we would be wrapping that up 12:30. The laboratory, which is also on site, would have the first set of teeth ready by about 3:30 or 4, and we would put those into the person's mouth, and then they would go home. And of course there'd be follow-up visits after that until they had healed and get their final teeth after about 6 months. And we'll talk later about why we do it that way. There are other people around the country who like to provide the final teeth immediately.
Yes.
And we've done that, and there are some problems with that approach to this particular problem, and I'll be happy to talk about the various things that we have run into and why we do things the way that we do them here at New Teeth Now.
Yes, so we'll get into, here's a picture of what the lower hybrid will look like, and then going into kind of what the steps for treatment are, which you kind of explained a little bit about.
Right. A few years ago we did things more traditionally, way back, probably in the 2006 time period, 2005, 2006, we had a more traditional flow where we were depending on a dentist who would send the patient to us, and then we would do the work and they would go back to the dentist's office, and then we would all interface with an outside commercial dental laboratory. And that worked well for a number of years, but as we became busier and busier and busier, the caseload couldn't be managed, and so we had to make changes in our business model and in our facility to accommodate our own dentist and to accommodate our own in-house commercial dental laboratory to be able to service us. And so we went from, as you see on this slide, the traditional flow to the next slide, which is the New Teeth Now, all in one day, all in one office concept, where the anesthesia, the implants are placed, all of the impressions are done here by the surgeons, the lab work is done here by our lab, and then the teeth are placed in the mouth by either the surgeon or our dentist. And so we've taken the three-ring circus where you have the dentist and you have the surgeon and you have the patient, and then they kind of intersect and we have one circle. And it's much more efficient, and communication is much better, and it works very well, particularly in these complicated type situations.
Definitely. And here is a look at our facility. So our surgeon, restorative doctor, and the lab is all right here.
And our anesthesia department.
Yes,
Yeah.
as well. This is Crystal, and we are going to show a little bit about her in a video.
Before New Teeth Now, I was in a lot of pain. My teeth were all loose. I was losing them one at a time. That's what made me pick up the phone and call New Teeth Now. My first appointment, I was very nervous, but Dr. Richards and the staff and everyone there made me feel so welcome. The day of surgery, I can't say that I was nervous. I have to say that I was excited. I was going to wake up and not have those teeth anymore and not have the pain anymore. I was really ready to get it done. My recovery after New Teeth Now was so easy. Now I have the best time with my grandchildren. I take them to parks, I laugh, I smile, I talk to people. It's just a whole different lifestyle. And I would recommend anyone that's going through pain or having teeth problems to go visit Dr. Richards. It makes me feel wonderful to know that I finally have a pretty smile after all these years, and I get to show people who I really am because I have a beautiful smile.
So Crystal had a wonderful, wonderful experience, as you can see. If you are live on Facebook, watching live on Facebook right now, you are able to send messages to us that we can answer during the webinar, so just to let you know about that. And now let's talk a little bit about zygomas, which is something that New Teeth Now specializes in.
Right. Zygomatic implants are used in situations where there's not enough bone in the rear, the back, whatever term you want to use, the posterior, the molar area part of the upper jaw. So frequently when teeth are missing, the sinuses will enlarge and the sinus drops down and there's no bone. And so the person is faced with a dilemma of doing a sinus bone graft or doing something like zygomatic implants. And up to, once again, around that 2006 time period, I did the traditional sinus lifts and bone grafts and waited months and months, sometimes 18 to 20 months to get enough bone to put implants in. And I had a failure. I had a patient that had a miserable failure back in 06, 07. And I had grafted her sinuses twice and they just failed to form any bone. So I went looking for a solution, which I ended up at an international conference in Las Vegas in May of 2007, and I heard a guy named Ed Petrosian out of the Pacific Northwest talk about zygomatic implants. And I said, that's what I need to be able to do. And so I made some arrangements. I got scheduled up with a surgeon up in Mississauga, Canada, Toronto, Leslie David. Went up, spent a couple of days with her, and I was like the first assistant putting in 3 or 4 zygomatic implants. And I came home, I did my first 2 the next day. So I started doing zygomatic implants around '07, and Bruce and I were counting up, I think, between Dr. Kirkpatrick and myself, and he came to zygomatics through a different track. So it's just sort of coincidental that, you know, he and I have kind of come together, and we both became very experienced in zygomatic implant placement. And I think we've done over 1,500 zygomatic implants.
That's amazing.
Since around '07, '08. Yeah, it's a bunch. More than it. As a matter of fact, we purchase more zygomatic implants than anybody else in the country. So we place more zygomatic implants than anybody else in the country. So we're kind of known for that, and we advertise that widely, actually nationwide. And people come here for that reason, because they have been told they don't have bone, or they have failed bone grafts. I've taken care of 2 other people from other surgeons that have had failed bone grafts, and zygomatic implants kind of saved the day. Kind of the Mickey Mouse of implants. But they're very good. This particular slide, are the viewers seeing that slide? This particular slide shows a person with enough bone to have traditional implants in the front part of the upper jaw, and then zygomatic implants in the rear portion of the upper jaw. There are other situations where there's no bone in the front and there is no bone in the back, so that they have zygomatic implants in the front and the back, and there would be 4 zygomatic implants rather than 2, and I think we have some slides of that. One of our viewers has a question. Yeah, you know, the Sjogren's syndrome basically dries up your saliva, and if you have no saliva, then you can develop rampant tooth decay. And I have done probably a dozen patients with Sjogren's syndrome over my time in practice. And of course, implants do not develop tooth decay, and you know, so they do work very well. To the viewer who asked that question, they do work very well in a environment where there's a lack of saliva for that reason.
Good.
But I think we have a couple other slides on zygomatic implants. You can see on the left slide there are 4 zygomatic implants, 2 on the left, 2 on the right, 1 more in the anterior and 1 in the posterior. And that's I'm doing one of those tomorrow and Thursday. This middle slide shows 2 zygomatic implants on the left, 2 zygomatic implants on the right, and a couple of traditional short implants right in the middle. And excuse me, the one on the left did have a single traditional implant, a little shorty right in the middle. So anytime we can combine short implants in the front, or even in the pterygoid region, which is way posterior, anytime that we can do that to supplement the zygomatic implants, we do that. And finally, the slide on the right shows a situation where there is just 4 zygomatic implants. And these cases, what these people have to understand and what we tell them is, I mean, they are at the end of their rope. They're hanging on to the last knot before they fall.
Right.
And there is nowhere else for these people to go. Bone grafting in that situation is difficult and unpredictable. It takes a long time, whereas 4 zygomatic implants in the hands of a trained, qualified surgeon can be inserted and the teeth done the same day, same process, and they can have all of that and walk out of this office with a fixed, non-removable set of teeth the same day, as opposed to months and months and months of healing and bone grafting and all that, which may or may not work.
Right.
So, I mean, it's
That's
like a
amazing
no-brainer
difference.
situation
Definitely.
with that.
Dr. Richards, we have another question.
I see that.
And I don't know if you've counted recently, but one of our viewers wants to know how many Zygoma implants you've placed.
I think we looked last week actually, and I've done, I think it's 800.
So quite a few.
Yeah, I think David's done maybe just a shade more than I have. I've done about 800. He's done about almost 900, and we had about 16 or 1700, something like that. We had a bunch. Antibiotics, yes. Whether it's a single implant, a double, triple, full mouth, single jaw, we do pre-operative antibiotics. On our full mouth cases, we give a large dose of intravenous antibiotics during and after, before the IV is removed later in the day. And the other question I have here that we'll just go ahead and answer now, what type of care do implants and the teeth need? Well, basically, they need the same kind of care that your teeth need and that my teeth need, which is a toothbrush, a water pick, and dental floss, which is what I do every day. And that's what a person would do with a set of these teeth that are fixed in their mouth. They would brush them with a toothbrush and use a water pick, and I describe that as, that's sort of like a pressure cleaner. Any of the food that would get trapped between the teeth and the gums, that kind of takes care of that. And then use either dental floss or little brushes, and that's what you do.
Routine maintenance.
Typical recovery time from a full mouth reconstruction, it kind of depends on what you're intending to do. I've had some people play golf the next day. I've had other people say it was 2 or 3 days before they felt like playing golf. But the recovery time is typically 2 or 3 days, I'd say. I've had people go to work the next day after having a full upper or lower.
Wow.
It's not unusual. So where were we? Let's go back to those
So tell us-
X-ray pictures.
Oh yeah. Let's see.
One thing I'd like to comment on is our process. And one thing that I keep repeating, and I would like to keep repeating, because I've been doing this a long time. This will be my 40th year in practice this year, and I've been doing these implant full mouth things since '83. So I got a few years under my belt and about 15,000 implants. So I've done a few. I probably hadn't seen everything, but I've seen a lot. And I have done teeth in a day. I've done teeth in 3 days. I've done teeth in a week, couple of weeks. I've backed up, and that's the final teeth now. I've done the final teeth in a day with a very close relationship with the lab. Final teeth in 3 days, final teeth in a week, and a couple of weeks. Done all of that. And what I have found is that, the people forget about the implants, because when they look in the mirror, they don't see the implants. They see their teeth.
Right.
And when other people look at them, they see their teeth. And so the teeth have to look good. They have to like their teeth.
Mm-hmm.
And they have to feel good in their mouth. And they have to be able to speak and enunciate words. They have to be able to talk without spitting out of their mouth. And, there's all sorts of little innuendo. And so what we found out early on is if you do the final teeth and then you have to make changes, and it's frequent to have to make changes, that you got to back up and remake the final teeth again. So we learned a long time ago that making the final teeth too early is not the right way to go. So many people want to change the teeth. They go, yeah, I made a mistake. I want them whiter. There's never a person that wants them darker. And so, you know, they want them whiter. They made a mistake, or they're, you know, not big enough, or they're too big. Invariably, there's a considerable number of people now, when we make that first set of teeth, and then 6 months later, when they're getting their final teeth, they want to change the teeth. So by making a temporary set of teeth at first, they literally get to test drive that set of teeth.
Yeah.
And
That's good.
from a cosmetic standpoint, what their friends see, what their family sees, what they see when they look in the mirror are the teeth. And so that's a big deal. Now, secondarily, after the procedure, there can be swelling and then shrinkage. And when there's some shrinkage, you get these big gaps opening up between the teeth and the gums. And so once again, if they're in their final teeth and you've got, you know, somebody that's a long ways away, that becomes a problem, because now you got to see them again and do all that to add material here and there. So we prefer that the person who's in New York, they go home with teeth that they know are temporary, and then they know that if gaps open up, or if they want to change their teeth, that they can do all that when our restorative dentist, Dr. Dibbs, makes their final teeth.
Right.
The other thing is, no matter how good we are, there will be some implants that fail to bond, or you might even get a little infection or something. And by holding off and waiting to do the final teeth for several months, we get to make sure that all of the implants are safe and secure and fully bonded. So those three reasons. So the person gets the teeth they like, so that we make sure the teeth follow the contours of the gum tissue so there are no big openings, and we make sure all the implants are healed before we put the zirconia teeth on the implants. And those three concepts are really important for you as the viewers to understand, because I can tell you that with 35 years of experience of doing this, and probably Lord knows how many of these cases, 5,000, 6,000, who knows.
So can you tell us a bit about the difference with mini implants and traditional implants?
Well, mini implants are very small, and they're typically inserted into narrow ridges. And first of all, we don't do mini implants. Mini implants are typically intended to hold a removable denture. And so in our New Teeth Now process, our patients get fixed bridge work. And so we need implants that are strong, that are sturdy, that are placed into good bone, so that these implants can support a fixed bridge, not a removable denture. So many implants really don't have a place in the New Teeth Now protocol.
Okay. All right. So why don't you tell us a little bit about your wonderful team that you work with?
I do have a wonderful team. These gals are all hard-working gals, and we have a lot of fun during the day. The four of these gals, they probably take out and put back more of these hybrid restorations and fiddle around with implant parts and pieces than probably most all the dentists in the state of Florida combined. I mean, they you know, this is true probably for any oral surgeon's team of women. I mean, or even guys. I shouldn't be saying just women, because there are male surgical assistants. But I would say in our profession, in oral surgery, when you've got these gals, they're extremely knowledgeable. They have knowledge about all of these dental implants. They have knowledge about anatomy, particularly about anesthesia. And so a lot of these ladies that work for all of these oral surgeons across the country, they are smart cookies and hard workers. You got to respect them.
That's awesome. We have a question here.
Well, you could have this procedure if you have if you can get a medical clearance, because we're going to put you under general anesthesia to do the procedure, and I can promise you, you will not have any myoclonic jerks under general anesthesia. So the issue is, why do you have those, and is there a medical condition that would preclude you from being able to have an anesthetic?
Okay. And speaking of anesthesia, this is our anesthesia team.
Yep.
We have Jack, Daniel, and Kim Sherry.
Yeah, who else can have an anesthetist named Jack Daniel? I mean, come on, you can't make that up. It's actually Patrick Jack Daniel, but anyway, Jack and Kim have been working for us for a number of years. They're both certified registered nurse anesthetists, and they provide our anesthesia services so that we, Dr. Kirkpatrick and I, can concentrate on what we're doing about doing the procedure. And while we're talking about anesthesia, we're talking about general anesthesia. We're not talking about IV sedation. We're not talking about twilight sleep, whatever that is. We put a breathing tube down and you are asleep, just like at an outpatient surgery center. And the benefits are many. Number one, as the surgeon, I can move on through the procedure and do something in 3 hours that might take a person under IV sedation 4.5 hours, because you have to stop for them to take a break, and they're choking, and they
Right.
need to rest, and they can't breathe, and this, that, and the other. So general anesthesia, because the person is totally asleep, the airway is totally protected. The little tube has a balloon on the end, and then we can pack gauze on the back of the tongue, and it doesn't choke the person because they're asleep. And so we can irrigate when we're drilling. We use a lot of sterile saline irrigation. We can irrigate. The person's not going to choke or gag because they're asleep. And if you've been to sleep, and probably a lot of people watching this, in my age bracket, the age bracket of the people watching this, have been put to sleep for something, a colonoscopy, or they've had an operation or something. And the nice thing is the light switch gets turned off at about 8 o'clock. And then it's like the light switch gets turned on at 12 o'clock and you're done. And so general anesthesia is a wonderful thing. Now, that being said, and when you consider the age bracket of the people that we work on, I mean, we're not talking about 20 and 30-year-olds here, typically. I mean, our typical clients are 60s, 70s, and 80s. So we get a lot of questions about that. How do we handle that? Well, we get medical clearances on everybody. Everybody. Even a young person who's, say, in their 40s, if they're healthy, we still get a cardiogram, a basic metabolic profile, and blood work. And so we are extremely careful and cautious with our general anesthesia. And, first and foremost, we don't want to do anything to harm anybody. And we've never had a problem with anybody in the office. And that's because we pick and choose, but occasionally we put somebody into Lakeland Regional Medical Center to do the New Teeth Now procedure because their physician advises that they're not a good candidate for an outpatient procedure. They need to have need to do it inpatient.
Right.
So we get a lot of questions about the anesthesia and how we manage that, and that pretty much sums it up right there.
So what is happening during surgery in the on-site dental lab?
During the surgery?
Yeah.
They're probably up there drinking coffee and eating donuts. Because they get fired up after the surgery. So during the surgery, I take impressions of the implants inside of a denture, which is similar to this denture, but we make special dentures. And so the special dentures that we make are surgical guides and bone trimming guides, and we take the impressions inside of the denture. So then at the end of the procedure, those records go upstairs. And those records are combined with the records that Dr. Dibbs took before the procedure. And using that, then the lab creates the first set of teeth, these acrylic temporary bridges. And so the upper one looks like this. It's a horseshoe. It doesn't have a palate. And although this is a zirconia one, it still is the same. The first set of teeth is the same as the zirconia. It's just the material that it's made of. So the upper has no palate. And then on the back side of each of the teeth, whether it's upper or lower, are these titanium cylinders in the teeth. And these titanium cylinders set on the implants, and there are little screw holes. You probably cannot see those, but there are little screw holes through the teeth where the little driver is introduced to tighten the screws that hold the teeth down to the implants. And so in the lab, all the action starts after the surgery. Otherwise, they probably have, policemen up there eating donuts and smoking cigars or something. I don't know what.
So we have two restorative doctors, Dr. Nafala and Dr. Dibbs. And we'll learn a little bit about Dr. Dibbs here.
One of the things that really sets Florida Dental Implants apart from other offices that are doing full mouth implant reconstruction, I have my own laboratory here on site that myself and the other restorative doctors are able to use. This is invaluable. Having the ability to work so closely with my lab gives me the ability to better help my patients with the emotional side of it as well. A large number of the patients that come to us for treatment have had severe dental problems for many, many, many years, sometimes dating back to childhood. Because of the emotional concerns that they have, we really have to spend the time with the patient. That you can't rush anything. And we need to have ample opportunity to have questions asked and answered. Having my own laboratory here on site, this is invaluable, not only in terms of having the control over the quality of the product that we're making, but the ability to, if I've got a question with the patient about, can we make this change? Is this going to be feasible? I can go across the hall, get one of my lab technicians, and all of my lab technicians have been doing this for many, many years. Bring them across the hall and they can talk to the patient themselves. So we eliminate the need for me to try to interpret the patient's concerns and questions and needs in a phone call or in a note. They can speak directly to the patient.
It was so important to me to have everything under one roof. There's no waiting. That is the advantage of having the lab on site. And they are so proud of their work that they come out to see the product. These are not regular people with regular jobs. These are master artisans that create. They truly are artists. And they're creating beautiful smiles.
It's like nothing I've ever experienced, and I don't know of any other office that's like this.
So Dr. Richards, what do our restorative doctors do with patients? Well,
the restorative doctor plays an important role in this overall process. This process, this New Teeth Now process, it's a team effort. It takes a combined effort of the restorative dentist, Dr. Dibbs and Dr. Nafala. It takes the laboratory team. It takes the surgical team. It takes the anesthesia team. It takes the implant treatment coordinator who coordinates all the medical clearances and deals with all the financial issues. So when you consider how many people are involved to make this happen, I mean, it's really kind of mind-boggling that we've been able to put all that together. But that's how that works. So, but the question was, what do the restorative dentists do? Well, specifically, they see all of these patients before the procedure. So, for instance, a person might come in and see me or see Dr. Kirkpatrick, and let's say they talk to the coordinator and they say, okay, I'm good to go. Where do we do next? Well, what we do next is we see Dr. Dibbs or Dr. Nafala. And when they are interviewed by Dr. Dibbs or Dr. Nafala, they get more information. Those two dentists, they do a thorough exam. They talk about teeth and the size and the shape and the color and the prosthesis and show them examples and take impressions. They take pictures. They take all the records. So all of that's very important, so that the person, before they have anything done, they've heard from the surgeon's end of things. They've heard from the restorative dentist, that end of things. So they've got a complete picture of the entire process. They know how long it's going to take. They know how many visits they're going to be. I mean, our patients are really informed before so it's not like they jump into something uninformed.
Right.
So,
Definitely.
and the restorative dentists play a big part of that.
So here is a really interesting picture. Tell us a little bit about the difference between these two teeth.
So the teeth here are about 5 years old, and the top is a zirconia with porcelain stain, porcelain glaze, and the teeth underneath are acrylic base with denture teeth set into the acrylic base. And so you're dealing with acrylic, which still some doctors provide the acrylic as the final restoration,
Right.
but it is certainly not durable, as can be seen here. The acrylic is porous, it accumulates stain and debris, it is more prone to breakage, it is more difficult to keep it cleaned. Whereas glazed porcelain or glazed porcelain stain is not porous, it's easy to clean, it does not absorb stains and odors, so it's much more hygienic and durable. And the teeth with the porcelain certainly reflect light more like natural teeth, and it looks much more natural.
Definitely. And so here are implant coordinators, and these are to Shauna and Debbie, who you would meet with if you came in for a consultation.
Right.
Right?
And both of these ladies have been with us a long time, 20 years. And both have surgical backgrounds. In other words, they have both been oral surgery surgical assistants. So they know a lot. I mean, they really
Yes.
know a lot.
Yes, they
And so they're able to talk to people on the phone, and we know that the information people on the phone are given is very accurate when it comes from our people here. And I can't say enough about Shauna and Debbie. Can't say enough good about them.
And this is what our CT scans look like. So this is something that you would have when coming into a consultation,
Mhm.
right?
Right, we pretty much do a CT scan on everyone.
Mm-hmm.
Be
And
able
then,
to look at the bone from different angles and different perspectives. Like this picture just shows there are different angles and perspectives that we can look at the bone compared to a traditional radiograph, which provides limited visibility and limited analytic. You can't analyze where the bone is on a traditional radiograph.
all right.
This is Bruce Cerny, who I know well, actually lives close to us down here, and Bruce had some advanced periodontal disease, and we got Bruce fixed up. It's golly, maybe 3, 4, 5 years ago now, and I know he was a happy camper after that.
He looks amazing. That transformation is just incredible.
Did you guys have a video with Bruce or no? This is a lady from Poinciana. She was funny.
No more videos.
Okay, all right.
Yeah.
But this lady, she didn't want to smile either.
Mm-hmm.
And when she came in, one of the first things she said was, she goes, "I want to be on your website." And she goes, "Where is the man that I talked to about getting a video?" And she was a pleasant gal, and she certainly liked to smile after she was after her treatment was wrapped up.
I know. Look at her. She's on
Yeah.
her website now.
Yeah, big change.
Definitely.
It's very common to see when their mouth and facial appearance changes, that their hair changes, that their clothing changes. I don't know that I've seen a spouse change yet, but people, you know, they come out of their shell for sure. Their personality changes, and it's, as I told someone after listening to, who was it, Ted? We were listening to Pam's video, and I was telling someone that after listening to Pam is one of our lab technicians. After listening to her video, that it is almost a humbling experience to know that what we do can do so much for the complete person. And something that we take so lightly. So I do this every day. And I don't think that much of it. I think it's nice that I can do that for people, and that we have the experience to do that. But when you hear a person on the receiving end talk about what it's done to their life, and they're not talking about eating in their teeth and stuff like that. I mean, they're talking about their life,
Changing
their
whole
social
life.
life, everything. It really is. I mean, it's a humbling experience. It really is.
If you are interested in learning more, we want to talk to you, so please reach out. Please give us a call, schedule a consultation. We want you to do your research, learn all that you can, so you can feel well informed and confident and ready to go with this procedure. So we look forward to speaking with all of you, and we thank you all for joining us tonight. Thank you, Dr. Richards, for
Yep.
taking the
Thank you.
time to be here with us, and we hope that everyone has a good evening.
If you would like to view more informational videos on New Teeth Now, please click the subscribe button here. Thanks for watching.